We're very glad to have our speaker today for John's seminar, Dr. Jenna Mueller from Duke. And before she starts, I want to give a quick introduction to Dr. Mueller. So Dr. Mueller works with Center for Global Women's Health Technologies at Duke University to develop accessible biomedical devices to improve the management of cervical cancer in low and mid-income countries. So it's a very different setting for applying medical imaging technologies. And Dr. Mueller received her PhD in biomedical engineering from Duke University, and for her work developing optical systems and automated algorithms to improve accuracy of cancer excision during surgery. And what is exciting about her system is not only for diagnosis, but also for therapy. And we want to hear more details from Dr. Mueller. Let's welcome her.
Thanks for the introduction and for the invitation to speak today. Can you all hear me okay? Okay, great. Today I'm going to be talking about several technologies that I've developed that are at different stages in the translational pipeline, but they're all geared at increasing access to care, particularly for women with cervical precancer and cancer. Cervical cancer mortality around the world is really high, in particular in low and middle income countries, or LMICs as I'll refer to them for the remainder of the presentation. This is a map of cervical cancer mortality where the darker colors indicate increased deaths due to cervical cancer. In fact, 84% of the 270,000 deaths due to cervical cancer this year will be in LMICs, primarily because a significant proportion of women are still not being diagnosed and even fewer are being treated, contributing to a huge global economic burden. These problems are also seen actually right here within the United States. This is a map of North Carolina where cervical cancer mortality is really high, particularly in counties that have low socioeconomic status. And so it's really a disease of poverty. And there's this interesting relationship between global health and what we see in rural communities throughout the United States. However, we have the opportunity to address this problem because cervical cancer is well understood. It's slow growing, meaning we have a long time to intervene. And if diagnosed early, is extremely treatable. The cervix is located in the female reproductive system in between the vaginal canal and the uterus. And at the center is a cervical os, where you have a transition from squamous to columnar epithelium. If this area is infected with a human papillomavirus or HPV, you can get the growth of a precancerous and eventually a cancerous lesion. This is a schematic that shows that progression. So here you have the lumen at the top and the stroma and basement membrane at the bottom. And essentially what happens is HPV slowly integrates into the DNA of epithelial cells, leading to uncontrolled cell proliferation and neovascularization. And here you can see the progression from low-grade precancer to high-grade precancer, and eventually to invasive carcinoma, where it invades the basement membrane and can spread to the surrounding reproductive tract and beyond. But what I want to point out is that this disease is not symptomatic until you get to this stage, where a woman can experience pain and bleeding. So that's why it's so important to screen women in order to catch it at this asymptomatic precancerous stage. In the United States, we have been able to substantially decrease our rates of cervical cancer through having a multi-visit paradigm. In this paradigm, women are screened with pap smear every 3 years after the age of 21. And in this exam, a speculum is placed to enable visualization of the cervix. And then a swab is used to swab the area around the transformation zone. And those cells are then sent to a pathology lab to stain and for pathologists to review and diagnose. HPV co-testing is also now used for women over 30. If a woman is positive, she's asked to return for a second exam called colposcopy guided biopsy. And in this exam, the speculum is placed again. Acetic acid is applied to the surface of the cervix to highlight lesions. And then a gynecologist will view the cervix with this device called a colposcope that you see pictured here that provides illumination and magnification. If any areas look suspicious, then a biopsy is taken, and that biopsy again is sent to a pathologist to review. If a disease is seen in women, particularly at the precancerous stage, then she's asked to return a third time for a procedure called loop electrosurgical excision procedure, or LEEP. And essentially in this exam, an electrocautery tool is used to scoop out the transformation zone. And this has high success, both good safety and efficacy. And if treated, women will not go on to develop cervical cancer, and actually there's no long-term complications for having children, for example. However, profound barriers exist for implementing this in LMICs for a variety of reasons. The first is up to 75% of patients are lost to follow-up care, meaning they don't come back for subsequent visits. And so because of this, the World Health Organization recommends a see and treat approach where women can be diagnosed and treated in the course of a single visit. Additionally, techniques like pap smear and biopsy require pathologists. However, there's a severe lack of a pathology workforce in many of these countries. A recent study that came out found that there's only one pathologist for every 2.5 million people in the country of Tanzania, and we have over 140 times that workforce in the United States. And then lastly, technologies like HPV and colposcopy, and LEEP require a high initial capital investment, access to constant power supply, which isn't always available, particularly in these rural communities and low-income countries, and also banking of samples for HPV testing, which doesn't lend itself to this idea of a see and treat paradigm. So to summarize, there's this 3-tier visit system that we have that's the standard of care in the United States and many countries in Europe, but that's not feasible for use in LMICs because of the medical infrastructure and expertise required to sustain it. And so this requires a new vision for addressing this problem, one where women could potentially test for HPV at home, and then if HPV positive, they could be seen and treated in the course of a single visit. But to realize this vision, we need new technologies that are more affordable, they're easy to use, and can potentially enable diagnosis and treatment at the primary care level, which is more accessible in many of these communities, and ones that could potentially take advantage of mHealth, or the idea that cell phones are so ubiquitous around the world and can be used to increase communication between patients and providers. So in this talk, I'm going to discuss 2 key technologies that can be used to enable care in these communities. The first is the development of a pocket colposcope to diagnose women with cervical precancer and cancer. And the second is a low-cost ablative therapy based on ethanol. And then I'll briefly transition and talk about my planned work. So first, I'd like to talk more about cervical cancer screening. This is the colposcope that I mentioned before. It costs upwards of $20,000 and weighs over 150 pounds and is about as tall as me. So this is expensive, not portable, but it does achieve high sensitivity. So because this isn't able to be implemented in LMICs, the World Health Organization recommends alternative approaches for screening women. One that they recommend is visual inspection with acetic acid, or VIA. And in this exam, the same speculum is placed and acetic acid is applied to the surface of the cervix, but rather than viewing the cervix with magnification, instead they just use the naked eye and some sort of light source. So here you can see a provider using a headlamp. So while this is cheap and portable, you can imagine that you would miss lesions. So it has low sensitivity. In fact, it's about half as sensitive as colposcopy. So we wondered, could we bring colposcopy to settings where VIA is done, but at a fraction of the cost? One reason why the standard of care colposcope is so expensive is because it has this really long working distance. So we thought, what if we could throw away those components and instead place consumer-grade electronics at the tip of a probe and bring it up close to the cervix? And this was inspired by transvaginal ultrasound. So over the course of several years, we developed the pocket colposcope, which I have here. It costs about $100 to build. It weighs less than half a pound, and it can be plugged into a laptop to both power the device and enable image capture. So I can pass this around. Inside the pocket, there are several key features. First is this ring of LEDs. We have both white and green LEDs. Green are to enable enhanced visualization of vasculature. And in the center is a CMOS image sensor. We also spent quite a bit of time optimizing the light path. At the tip of the probe, we had some light leakage directly into the CMOS sensor, so we implemented a strategy to eliminate that. And then lastly, the camera rests in this camera sled that's connected to a magnification slider, which enables the user to focus it at different working distances. But we didn't start out with this product. Our first prototype was developed in 2013, and a key aspect of my work is using human-centered design. And I know that that's an emphasis here at Dartmouth in your curriculum. And so the goal here is to design with end users rather than designing for, so we end up with a solution that's better able to address the initial problem. And so this just shows the iteration of the device over time. And essentially, through engaging with end users, both at Duke and in countries in East Africa and South America, we were able to eventually meet all of the desired design specifications with our beta prototype. And one that I like to point out is that this device had to be easy to clean. Technologies like autoclave and ETO gas sterilization, which are used to sterilize a lot of medical equipment in this country, aren't available in LMICs. And so we spent a long time waterproofing the device and making sure that we could submerge it in bleach or Sidex, which are available in these communities. We also spent quite a bit of time developing different benchtop tests that could be used to quickly assess image quality and ensure that it was being conserved over the iterations of the device and that it was comparable to the standard of care. So this is a cervix mannequin that essentially we placed in a black box, and we looked at the signal we were getting from the cervix relative to the background, and we could do this for both white and green illumination. We also took images of a resolution target to assess resolution and field of view, of a distortion target to look at distortion, and then a depth of field to assess depth of field. We've published several papers on this that demonstrate that our imaging performance was conserved across generations of the pocket and was comparable to the standard of care. But we also wanted to ensure that this device was achieving comparable clinical performance to the standard of care colposcope. So this is a study design for a study that was recently conducted in Peru. Essentially, the speculum was placed and a contrast agent was applied. A quick image was taken with the pocket, and then the exam proceeded per the standard of care. So an image was taken with a standard of care colposcope. That was then used to guide biopsy, which was sent to pathology and was an independent metric that we could compare our images to. And then the images were randomized after the fact and sent to 4 different physicians who filled out a survey and scored the cervix. These are representative images from this latest study. Here you can see the standard of care colposcope across the top and the pocket across the bottom. This is an example of a normal, low-grade, high-grade, and invasive cancer patient. And these arrows essentially point out areas that looked suspicious to providers that were then biopsied. And what you can see is very comparable features across the top and bottom row. These are these same cervices, but stained with a different contrast agent called Lugol's iodine that's commonly used in Peru. And essentially, this stains for glycogen content. So precancerous lesions have low glycogen content, and so they turn this mustard yellow color as opposed to the normal tissue that's brown. So it very nicely delineates where these lesions are. And when sent to providers to provide a diagnosis, we found that the pocket and the standard of care agreed around 83% of the time. And then when compared to the independent metric of pathology, they found around 65% agreement with pathology, and comparable sensitivities and specificities. But what I want to point out is there's quite a bit of variability here, even among expert-level providers. And so another avenue of research is to develop initial smart algorithms that can essentially decrease this variability in diagnosis and also enable this idea of task shifting that I mentioned earlier, where you're enabling expert-level diagnosis at the primary care level. So to develop these algorithms, we wanted to take advantage of both the acetic acid and the Lugol's iodine staining. First, we segmented out the region around the os through using Gabor filtering. And then in those regions, we looked at the color information, in particular in different color spaces to capture this mustard yellow color. And we also looked at texture features. There's additional texture that you can see here. It's a phenomenon called mosaicism that we wanted to capture. And then these features were fed into a support vector machine that generated classification scores, which then through cross-validation were used to generate this receiver-operator characteristic curve where you have sensitivity versus 1 minus specificity, with the goal to get as close to this upper left-hand corner as possible. And what you can see here is that when we combined features, particularly from VIA and VILI, which is indicated by the green curve, we outperform expert-level providers, which are indicated by the black dots. So our hope is that through using the pocket and combined with this algorithm, we could meet these initial design criteria. The SMART algorithm is currently being validated in a multi-country study. Over 700 women have been imaged so far across 7 different countries. We also received regulatory clearance through the 510K pathway this past year and got an SBIR grant to launch a company and hand this off to a contract manufacturer. So it's been a great project for me to be a part of from the early research stage through to the point where we're getting ready to sell units in 2020. So next I'd like to transition and talk more about treatment. LEAP is the therapy that I mentioned earlier, which is essentially a surgery that's removing the transformation zone. This technology is expensive and it requires electricity as well as a gynecologist to perform. So consequently, the World Health Organization recommends other approaches for treating women in LMICs. That are based off of ablative therapies. So one ablative therapy that's the most widely used is cryotherapy. And essentially, with this technology, you have a tank of liquid nitrogen that's used to cool down a probe that can then be used to freeze the lesion. But this is moderately expensive. It's around $90 or so a treatment, and it still requires these large gas tanks, which are difficult to procure and transport into these communities. Another ablative therapy that is gaining some popularity in LMICs is thermocoagulation. And this essentially uses heat to cause necrosis in a lesion. But it's still moderately expensive on the order of what cryotherapy is. It requires that you plug it into the wall, and the probes must be regularly replaced. And so there's still some challenges with that as well. So because of this, I'm interested in developing a low-cost treatment based off of a different technology, specifically ethanol ablation. And this essentially what someone does is takes a syringe with ethanol and injects it into a lesion to cause necrosis. And it does that through a couple different mechanisms. While water molecules and other solutes can enter the cell through pores, ethanol can actually directly diffuse through the cell membrane because it's slightly lipophilic or lipid-loving. And once it dissolves the membrane, it allows ethanol to further pour into the cell, which can denature proteins and essentially melt the cell from the inside out. This has actually been used to treat hepatocellular carcinomas that are inoperable and under a certain size. And essentially with this, the needle is inserted under ultrasound guidance, and then the ethanol is infused into that region. And this has been well tolerated by patients. So we wanted to take this approach and try it in an epithelial lesion. So initially we selected a hamster cheek pouch model of oral squamous cell carcinoma. So tumors were formed by topical application of a carcinogen, DMBA, over a series of weeks. And then ethanol was injected into the lesion in the hamster cheek pouch, and the tumor was measured over 7 days. And what we found is that by day 7, tumors were about 30% of their initial volume. So there was some response, but it definitely could be better. Some of the reasons why we thought that it could be better are demonstrated in this video. Oops, let me go back. So here, a blue dye was added to the ethanol, and essentially what you see is that it's immediately leaking right out into the surrounding cheek pouch. So essentially, it's a flash in the pan. It's not sticking around long enough. So the first issue is localization. And we were doing manual injections with this, which are around 100 milliliters per hour. But those high injection rates can actually cause leakage or cracking of the tissue. So one way to improve localization is to reduce the injection rate. Another issue is retention. Once you inject ethanol, you want it to stay where you initially injected it. And low viscosity solutions like ethanol can be quickly cleared by the body. So one way to improve retention is to increase the viscosity of our solution. And these concepts were informed by biofluid dynamics, in particular Darcy's law, which talks about the relationship between volumetric flow in poroelastic media, such as biological tissue. So if we want to keep volumetric flow low or keep ethanol in the region where we inject it, 2 ways to address this are to decrease pressure and increase viscosity. Others have demonstrated these concepts in the literature, in particular when injecting tumors. So this group found that defects form under high injection pressures, particularly this concept of crack formation in heterogeneous tissue. Further, when injecting a adenoviral vector encoding luciferase, which is bioluminescent, they found improved retention when the injection rate was controlled. And then lastly, viscous solutions like this polaxamer they found were better retained in the tumor. So with these concepts in mind, we wanted to reduce the injection rate and also increase viscosity. So to increase viscosity, we selected this polymer ethyl cellulose for several reasons. One is that it dissolves in ethanol, but once it hits water, such as in tissue, it forms this gel that retains the ethanol in the area where we've injected it and allows it to slowly leak out over time. It's also low cost. It's a few cents per injection, and it's generally regarded as safe by the FDA. It's in the past been used to coat a variety of pills and also as a thickener in cosmetics. We also found that ethyl cellulose ethanol has previously been combined to treat patients with venous malformations and herniated discs in Europe. It's been used in over 700 patients, And while they found some minor local side effects like swelling, edema, some pain, they found no systemic side effects in these populations, indicating it's safe for clinical use. So next we wanted to understand what concentration of ethyl cellulose to use and get a better grasp on this gel formation. So first we found that viscosity increases exponentially with ethyl cellulose concentration, but it doesn't significantly alter the cytotoxic activity of ethanol. So here we still got a significant decrease in viability with the addition of ethyl cellulose compared to control. We also found that gel mass depends on water concentration, the concentration of ethyl cellulose, and time. In particular, I want to draw your attention to this graph here, where we found a significant increase in the gel mass around 3% ethyl cellulose. And so we were interested in using concentrations of 3% and beyond. So next we applied this back to our hamster cheek pouch model and found that after 7 days, the lesions completely disappeared. This is a normal cheek pouch. Further, when we controlled the injection rate and reduced it to 10 milliliters per hour, we got complete regression of all tumors that were injected with ethyl cellulose ethanol, as indicated here. So with these initial promising results, I went back to the cervix and applied for a K99 to optimize the delivery of this to treat cervical precancer. And this work includes 3 aims. The first is to establish a method to optimize delivery, then to use that optimized delivery to treat a large animal model, in this case pigs, which have a similar size cervix to humans and similar morphology. And then in the R00 phase to transition to working with cervices obtained from women undergoing hysterectomies. So I'm going to talk about my work in aim 1 so far. So in order to optimize the distribution volume, first I needed a way to track where ethanol was going. So fluorescein easily dissolves in ethanol. And I modified the tip of the pocket colposcope to be able to image fluorescein by adding a ring of blue LEDs and a bandpass filter in the middle. And so here you can see a tumor that was injected with this combination and then sectioned. And you can nicely see the fluorescein distribution. You can also track the injection while it's happening with this approach. So here you have a needle in the center, and then you can see it diffusing through the tumor, through the skin. But ultimately, I wanted to see if fluorescein correlated with necrosis, because that's the endpoint I care about. So mice were injected with different concentrations of ethyl cellulose dissolved in ethanol with fluorescein added. And then after 24 hours, tumors were removed and stained with NADH diphorase, which stains viable cells blue and doesn't stain necrotic regions. So first from this, you can see that necrotic volume increases with ethyl cellulose concentration, and that necrotic distribution nicely correlates with fluorescein distribution, indicating that it can be used to optimize delivery. So next I did a study in superficial lesions where I looked at a variety of injection parameters in order to figure out what optimizes my distribution volume. So first, the needle was inserted to a specified depth. I chose 5 millimeters because that's the depth needed to treat 99% of cervical precancer. And then I varied the concentration of ethyl cellulose, the infusion rate, and volume with a syringe pump. After the injections were done, I flash froze the tissue and subsequently sectioned it with a cryostat and imaged each section with the modified version of the pocket colposcope. And then developed an image processing algorithm to quantify distribution, where essentially the fluorescein information is isolated in the green channel, thresholded, and then the border and small regions are removed to remove noise. So here are representative protocols. I reconstructed the 3D volumes, which you can see here, and then took a representative slice through the center of X, Y plane and XZ plane. And what I want to point out is that you get the largest distribution volume for 6% injected at 10 milliliters per hour. This was further quantified by looking at the target zone, or the depot, the area around the needle, versus the off-target area, or non-depot. So when we look at our injection protocols, we find that the total volume is highest for 10 milliliters per hour. But if we break this down, we find that the 3% actually leads to a significant non-depot volume, indicating that 6% injected at 10 milliliters per hour achieves the largest distribution volume in the target zone. So next I use this protocol on baried infusion volume. And here, essentially, what you can see is that 50 microliters optimizes the normalized depot volume, or the amount within the depot relative to the non-depot. So this information is being used to develop an injection device that I'm implementing in the in vivo pig study in AIM-2. So to conclude this part of the talk, I talked about several different technologies that are at different stages in the translational pipeline. The pocket colposcope, which is ready for handing off to a contract manufacturer. The smart algorithms, which are still being validated in women in the different clinical studies. And then ethyl cellulose ethanol ablation, which is at the preclinical stage. So next I'd like to transition and talk about my planned work. Moving into the human cervix, but then also a second indication for ethanol ablation in the oral cavity. And then lastly, I want to mention a new project that I've been working on to develop a low-cost laparoscope for laparoscopic surgery in LMICs, using a similar approach to the pocket colposcope. So next I want to talk briefly about my plans for AIMS 2 and 3. So for AIM-2, I'm moving in vivo in pigs. This is a schematic of the injection device that was just finished being developed. And essentially in this device, it allows me to do everything in this handheld form factor. So I can program the depth the needle is inserted at, the rate we infuse ethyl cellulose ethanol at, and the volume. But in order to reach the cervix in pigs, they don't use a speculum. And so a camera and a light source was incorporated into this device, so I know when I'm in contact with the surface of the cervix. And then this probe housing can be really easily removed and submerged to sterilize between animals. And then in this study, I'm comparing to thermocoagulation, which is one of the ablative therapies I mentioned before. So essentially, pigs will be treated with either thermocoagulation or ethyl cellulose ethanol, and then I'll monitor safety endpoints for 24 hours. And then at the 24-hour mark, the cervices will be excised to evaluate the volume of necrosis that we achieve with this therapy and compare it to thermocoagulation. And then in the R00 phase, I'd like to transition to thinking about the human cervix. So here, I plan to develop a multi-injection procedure, first through planning it out with simulations and the placement around the os, then verifying it in ex vivo specimens obtained from women undergoing hysterectomy. And then this information can then be used to create a prototype of a speculum-compatible injection device that will be assessed in vivo through a follow-on application, an R01, hopefully through the NCI. A second project area is in the oral cavity, and I'm a co-PI on a biotechnology innovation grant through the North Carolina Biotechnology Center to do some of this initial work. And in this work, we're using a rat model of oral cancer to establish the dose in particular that we want to use to treat the oral cavity, and then comparing it to surgical resection. This also has a commercial development aim. I've been working with a regulatory affairs scientist to identify the regulatory pathway for this technology. And then lastly, I'd like to mention this project in laparoscopic surgery, which is a new area of interest for me. Laparoscopic surgery is used for a variety of cancer surgeries and other surgeries in the chest and abdomen, and uses a laparoscope that's inserted through a trocar port and a few other small incisions to perform surgeries that in the past have been done through an open approach. This is the standard of care in high-income countries, but it's often not accessible in LMICs, again, because of the cost and the infrastructure to maintain it. But that doesn't mean that there isn't a need. In fact, untreated surgical conditions account for more deaths worldwide than HIV, tuberculosis, and malaria combined, which are traditionally thought of as the big three causes of death in LMICs. So through a class where we teach human-centered design, a pediatric surgeon and I have been able to work with a group of students to develop the initial prototype of this device. And we found that we can build it for around $125 for the cost of goods. And this is in comparison to the standard of care device, which is over $200,000 to outfit a single OR. Moving forward, there's additional features that we would like to incorporate into the prototype to do bench testing, to demonstrate equivalence to the traditional laparoscope. Here you can see initial images of a resolution target where our device gets a really nice quality image. And then apply for an academic industry partnership grant through NIBIB to optimize the design and move into preclinical and then clinical studies. And one potential partner is Third Stone Design that I have experience with through working on the pocket colposcope, though I'm also interested in exploring other industry partners. And then lastly, I would just like to acknowledge all of the people that contributed to this work, the students that I've worked with, Nimi, who directs the center, David, who is my key mentor on the P99 and has a background in biofluid mechanics, John, who is my key clinical collaborator on all of the projects related to the cervix, and then Tamara Fitzgerald, who is the pediatric surgeon that I mentioned. I'd also like to acknowledge active support, primarily through the NCI, North Carolina Biotechnology Center, and an intramural grant through Duke. And with that, I can take any questions. Thanks for your attention.